to everybody. Thanks for supporting me. And thanks, Arturo, for having me. It's really a great pleasure. What we have been seeing this afternoon is just how many things you did in this field, in the aortic field. But also, I like also to say that that I like to see how many young people surrounding you. If when we read the papers that you publish, you have an amount of people that following you. So that's from my perspective as a professor of University of Milan, it's the most important thing, creating a group. So my best congrats beyond the aortic knowledge, research, and everything. So let's talk a bit about the uncomplicated. Uncomplicated are those patients that present with the type B aortic dissection and do not present normal perfusion, no rupture, and even no high-risk features. One of these high-risk features is the entry tier over 10 millimeters, but there are also other issues that I will try to show you. It is important to say that in the last couple of years, we have 3 important documents on this field. So we have a reporting standard from SBS STS group. We have a guideline on type B aortic dissection from the AATS group. And finally, we have also in the same year, 2022, the ACCHA guideline aortic disease managed by Eric Selbager, who is another friend of us within the IRAD registry, and here so well represented by Alan Breverman. These patients exist. There is a discussion if they exist or not. These are data from the literature. At least 50% of type B dissection present with complication. This means that there are other 50% they do not present. And it is interesting to see how 4 different experiences have been able to show this point. On the contrary, there are, or on the opposite, not on the contrary, on the opposite side, there are several centers that say, okay, but these patients are going to be affected by aortic enlargement, so they require intervention. That's an interesting point from important institution, as you can see over here. For example, MGH said that 38% of medically treated uncomplicated required intervention, and similarly said that the Emory University on 46%. But to my eyes, this means also the opposite. Means that about 50 to 60% of these type B patients do not require any therapy. I'm talking about interventional therapy, open or endo, because I think that all of us have been facing with patients like this that do not dilate over time. Why they do not dilate while the other group dilate, we don't know yet, but there are, of course, radiologic signs, biological signs, molecular signs, medical treatment issues that need to be highlighted also in the next years. So if we talk about therapy, all the guidelines that I showed you say that optimal medical treatment is recommended initially in this patient. This is pretty clear. We have solid data about this. But we have also data about prophylactic TEVAR that may be considered in particular for reducing aortic-related adverse event in the mid or long term time. And this is exactly in line with the previous guidelines published at least here in Europe in 2014 by ESC and by the European Society of Vascular Surgery in 2017. But there is also something that I like to underline. In the last ACCHA guidelines, the concept of treating in a prophylactic way this patient with the stent graft is in particularly proposed for those who have high-risk anatomic features. And these high-risk anatomic features are different. It's a diameter of proximal intratear, partial lumen thrombosis, for example, number of vessels who take off from false lumen, saccular formation, total diameter of 40 millimeters, false lumen diameter over 22 2 millimeters. I have to say that we went through all these specific high-risk features, and we noted that some of these were validated by additional experiences, while others were not. And when we did a systematic review on all the features that could be associated with aortic enlargement over time in type E dissection, we noted that only increased aortic diameter over 40 millimeter may present a decent class of recommendation and level evidence. As you can see on the right-hand side in these slides, the green means that all these publications are in line with the statement, yellow are controversial, red are opposite. So these show how is confounding this type of issue in this time. And the other important point was that those patients presented with complete false lumen thrombosis were really associated with better outcome. Another interesting point that I like to highlight in this talk is the role of the anatomy. Anatomy was not mentioned until some years ago, at least for acute dissection, were mentioned for other diseases like aneurysm or blunt trauma. But anatomy matters, and matters because I will try to show you some slides related to forces and migration that, for example, stent graft may have during the time. But also the concept of the anatomy is coming up again as we treat complicated patients. For example, TEVAR says that is indicated in case of favorable anatomy, and open surgical repair still has a role even in acute complicated B in patients they do not present a feasible anatomy. And I think that we all face also with the different patients that present with the favorable or unfavorable neck for a standard TEVAR. I was saying that angulation and matters. We have data for proximal aorta where increased forces are associated with increased risk of migration and lesion. This happens not only proximally, but also distally. I know that also Arturo's group is associated with bioengineering, as we are running similar things in Milano. And when we have tortuosities, these are often associated with complications like retrograde dissection or distal-induced new entry. These are problems that are even more evident when these type of aorta are more present, in particular in the proximal section in arch type 3 in zone 2A3, as you can see on the left-hand side on this registry. When we have a patient like this and we want to treat because clinic, or because we think that although it's an uncomplicated patient, this may associate with a better outcome, once we tend to force the anatomy, we move in a different direction because we have to go ahead with more complex procedure. And more complex procedure and more complex anatomy most of the time may be associated with a higher force and with additional complications. So the idea is also to take in mind that anatomy, when we force the anatomy, we may have also other unexpected positive outcome. We believe in this field, we believe in this type of research, and this is one example of a patient who came to us with a refractory pain and hypertension with the very distal proximal entry tear in acute B dissection with a retrograde extension into the arch. And we looked into the lab with the engineer, and we noted that because the angulation was arch type 3, the forces in zone 3 and 4 were too high. And based just on this type of analysis, we decided to deploy the stent graft more distally, although was a diseased lesion, but a diseased aorta wall, but it was parallel. So we followed this point, and it's an anecdotal thing, but this is a concept that we follow also for other TEVAR, but also our other abdominal aneurysm when they need treatment. If we talk about importance of the arch, and I go back to the discussion that Martin said 10 minutes ago in terms of arch involvement in B dissection. There is a concept to treat this patient in a medical way, although there are no complications. And this data basically comes from the Fribourg group as well from the IRAD group that show that in those patients who present with an proximal entry tear into the arch but do not present an ascending involvement, a patient-specific approach can be reasonable. Another important thing is in terms of managing this uncomplicated B dissection is when to treat. Professor Eagle showed the concept of hyperacute setting, and we need to avoid this time because in this time we face with the most fragile aortic wall, so we have to shift ahead and tend to treat if we like, because we continue to talk about uncomplicated patients weeks later. I want to report some very recent IRAD data, almost 4,000 type B dissection. You see there is a decrease in medical and surgical therapy overall. There is a progressing increasing trend in endovascular management of these patients. If we look at the management of complicated and uncomplicated, there is an increasing trend to treat this patient with endovascular, although these are uncomplicated. But these next two slides are the most important. We are facing with a decreasing overall mortality, regardless the type of management that this patient necessitate, and we have a reducing mortality both for complicated and uncomplicated. Uncomplicated, as other authors said, is associated with no increased in-hospital mortality compared to those who were treated medically. There is a risk for mortality even if we treat this patient medically, even if we treat with endograft, but there is no increase in the risk associated with the use of an endograft within the in-hospital course. Of course, the new upcoming trials will clarify if we have to treat this patient, when to treat, how to treat, and this is part of my personal experience, specifically related to acute dissection. So to end up with some conclusion, now we are living in years in which we have some very important documents. We didn't have these till 3 years ago, I like to repeat, and we are also upcoming aortic guidelines from AAX and STS, AATS societies, so new data that are more or less in line with what the data that already showed. We have also the new reporting standard who can give us the opportunity to talk about the same patient with the same words about extension, location of proximal entry tear, presence of malperfusion or rupture or other things. We know that for uncomplicated optimal medical therapy is the baseline of the discussion. Prophylactic TEVAR has a role. This is clear. We are facing in this uncomplicated setting with the reducing mortality, and this is pretty clear. But I like also to say one more time that when we treat the patient, that is a single patient with a single anatomy, with a single biological status, and this should be taken in account before deciding to treat or not in an invasive way. So thank you very much for your attention.